Hello, this presentation describes a recent study which we carried out looking at understanding the outcomes and impacts of integrated care. The study was funded by the National Institute for Health Research. It was carried out by a team at the University of Sheffield. I'm Sue Baxter. My colleagues were Duncan Chambers, Maxine Johnson, Anthea Sutton, Elizabeth Goyder and Andrew Booth. If you'd like any more information about the study, please email me. My email address is provided on this slide. Efficient and effective working between different healthcare services and/or between health and social care is a major challenge for healthcare systems worldwide. Increased integration is charged with achieving more care outside hospitals, a greater focus on population health, and also financial sustainability in the future. In the UK, the drive to integration has been formidable, with Vanguard sites funded to test 7 models of integrated care. But what is the evidence from around the world regarding the effects of integrated care? In this presentation, I will outline the findings of a systematic review study which looked at available research evidence on the effects of changes to service delivery which aim to increase integration and coordination. I will outline reported outcomes of integrated care and highlight where the evidence is stronger, weaker, or is inconclusive. The data comes from a systematic review which included 267 studies. The studies related to integrated care and were carried out in developed countries around the world. We included other systematic reviews, quantitative studies which evaluated integrated care interventions, and qualitative studies reporting the views and perceptions of staff or patients. In this slide, you can see the range of different patient types and conditions that were in our included literature. You can see that much of the evidence came from studies carried out in older adults. But there is a range of different patient types and conditions within the evidence. I'm going to be describing the data using a pathway model. The pathway sets out the elements of integrated care, looks at the target areas for change that were reported in the studies, considers evidence regarding process changes, influencing factors, outcomes, and system-wide impacts. So if we first turn to the elements of integrated care, this diagram illustrates the range of different elements that could make up an intervention that was described as improving integrated care. You can see that the most common element was the introduction of integrated care pathways or integrated care plans, and these were particularly found in the UK literature. The second most commonly found element was the introduction of multidisciplinary teams. The third most commonly found element was the introduction of case coordinator or case manager interventions. These types of interventions were more commonly found in the non-UK international literature. You can see that there's a wide range of different types of element that make up integrated care, and many studies used a combination of these different elements. If we consider the second element of our pathway, what were the outcomes or the expectations of these integrated care initiatives? The target areas for change that were described by authors were that the integrated care programme should achieve more holistic or patient-centred care, might aid the development of shared values, beliefs or priorities, might improve relationships, improve levels of trust and support, improve mutual understanding, or improve communication. The studies describe the importance of change in these areas, and these were frequently described as the targets for change. However, it was noticeable that there was little data regarding actual change that had been achieved. In the following slides, I'm going to report the evidence in terms of strength. I'm going to describe where there was evidence of increase, no change, or a reduction in the outcomes reported. We've used increase, change, or reduction as it can be problematic to refer to positive or negative effects in this literature. For example, change which leads to increased patient access could be considered to be a positive change by patients, but could also be considered to be a negative change by services, as it might increase the cost of delivering these services. We used a 4-point rating scale to determine strength of evidence. In this rating scale, stronger evidence refers to generally consistent findings in high-quality studies. Weaker evidence refers to generally consistent findings in a single study of strong design or several studies of weaker design. Very limited evidence is where we only had a single study available or perceived changes only. And inconclusive evidence referred to where the direction of evidence was unclear, so fewer than 75% of studies reported the same outcome. If we think about the third element of our pathway, so what is the evidence regarding changes in process? We found no areas where we could rate the evidence as being stronger. We did, however, find 5 areas where there was weaker evidence of process change. We found weaker evidence of improved discharge planning, improved flow of care, which could be timeliness or improved coordination. We found weaker evidence of an increase in knowledge sharing amongst staff. We also found a potentially adverse outcome in terms of an increase in practitioner time. If we move now to thinking about the factors which might influence implementation or outcomes of integrated care initiatives, we found many different factors which were reported to influence integrated care. And this list is the factors where we rated the evidence as being stronger. In terms of patient-related factors, we had the focus of the integrated care initiative and the level of patient engagement. In terms of workforce-related factors, we had elements of professional identity, role boundaries, the stability of the workforce, power and hierarchies, staff training, and levels of staff engagement. Management and leadership influencing factors were whether there were local leaders or champions, and also whether the leadership was effective. Organisation and system influences were levels of resourcing, types and ability of information technology to deliver, clarity of vision, organisational culture, and the policy context. Financial and governance-related influencing factors were the commissioning type, governance, and also budgets. If we move now to thinking about outcomes of integrated care initiatives, we found 3 outcomes where there was stronger evidence of effect. These were stronger evidence of perceived improved quality. The UK literature tended to report staff perceptions of improved quality. The international literature tended to report patient and staff reports. There was also stronger evidence of improved patient satisfaction and stronger evidence of improved access to services. We found 2 outcomes with weaker evidence of effect. We found evidence of decreased length of wait, and this could be wait for initial contact, wait for diagnosis, investigation or treatment. And we also found some UK evidence which indicated that patient preferences could be more often met in integrated care. This evidence tended to be from services which tended to be for people at end of life. We found 8 outcomes where the evidence was inconclusive. These were number of clinician contacts, length of stay, A&E attendance, outpatient appointments, unscheduled admissions, readmission, and staff work experience. If we look at the final element of our pathway, so what is the evidence on system-wide impacts of integrated care? Here, the 4 outcomes that were measured, cost of provision, community care activity, secondary care activity, and healthcare utilisation, all provided inconclusive evidence. We looked to see whether there was the possibility of some subgroup differences, with integrated care being potentially more effective for particular patient types or conditions. We looked at the literature that had taken place in older adult populations and compared this to the general overall reports. We found no strong signals of difference in this evidence. We did the same for reports of studies in patients with complex needs. We found a suggestion of more effectiveness for this group of patients. In particular, in terms of admissions, where there was stronger evidence of a reduction in admissions. In terms of length of stay, where there was weaker evidence of reduction. And in terms of emergency department use, where there was stronger evidence of a reduction. While patient satisfaction had strong evidence from the overall evidence base, for complex needs we found only weaker evidence of an increase in satisfaction. So the headline conclusions of our study. There is evidence that new models of integrated care may increase patient satisfaction, may lead to improvements in the accessibility of service, and reduce the length of waiting times. The evidence is currently unclear for other outcomes, including the impact on service usage and costs. We emphasise that new models of integrated care act at a whole systems level, and it's important to consider incentives and outcomes across the whole system. We suggest that new models of integrated care may have more potential in certain patient populations, and the evidence is particularly indicating potential in those having complex needs. This study was funded by the National Institute for Health Research. The views and opinions expressed therein are those of the authors and do not necessarily reflect those of the programme, NIHR, NHS or the Department of Health.